of the home.
The Al Ansar Foundation, Dawah, Tarbiyah, and Education, establishing the foundations of Islamic civilization in South Africa.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والعاقبة للمتقين والصلاة والسلام على رسوله الكريم سيدنا محمد وآله وأصحابه أجمعين برحمتك يا أرحم الراحمين. All praise due to Allah, the Lord, cherisher, nourisher, sustainer, and master of the universe, the most gracious, the most beneficent, the most merciful. Ya Allah, it is only you that we worship and is your guidance that we seek. Ya Allah, keep us on the straight path. Ya Allah, shower us with your choice of blessings. Ya Allah, shower us with your mercy. Ya Allah, guide us. Greetings, salam, salutations on our beloved Nabi Muhammadur Rasulullah sallallahu alaihi wasallam. It's time for Medical Files, brought to you by the Islamic Medical Association of South Africa once again, and it's hosted by myself, Faisal MJ Sulaiman. Assalamu alaikum wa rahmatullahi wa barakatuh to all our listeners on Radio Al Ansar, CII Radio, Voice of the Cape, Radio 786 Sirius FM, Radio Islam, and IFM Port Elizabeth, as well as all listening to us on the various audio streaming and other platforms. Our topic for discussion this evening is diabetes control, and our very special guest is Dr. Hussein Ahmed Randri, an endocrinologist. Dr. Randri, assalamu alaikum wa rahmatullahi wa barakatuh, and jazakallah khair for joining me on the program this evening.
Wa alaikum salam wa rahmatullahi wa barakatuh.
Just to introduce our guest, Dr. Hussein Randri graduated in 1982 with MB CHB degree cum laude from the Nelson Mandela School of Medicine in Natal, South Africa, specialized in internal medicine, achieving the fellowship of the College of Physicians of South Africa in 1988. Thereafter embarked on a career in diabetes and endocrinology, being involved in both undergraduate and postgraduate teaching and research at the Nelson Mandela School of Medicine. Currently, Dr. Randri is serving on the scientific committee of SEMDSA, tasked to draw up guidelines for type 2 diabetes with special focus on Ramadan and diabetes, as well as guidelines for thyroid disease. He's a member of several advisory boards, both local and international, in the field of diabetes and endocrinology. He's currently in private practice at Parklands Medical Center in Durban, South Africa, and continues to be involved as a part-time consultant at the Diabetes Endocrine Unit at the Nkosi Albert Luthuli Hospital. Now, Dr. Randri, just to introduce our topic, what is diabetes and how does it affect the body?
Yeah, Jazakallah. Faisal, the diabetes, if we can summarize in one sentence, it's actually a chronic metabolic disorder that is characterized by an elevation in blood glucose levels. And of course, if the blood glucose levels are higher than normal in the body, that then has an impact on various organ systems in the body, which of course explains the complications associated with diabetes. And because we cannot look at metabolism in isolation, we must remember that indirectly diabetes also does affect protein and fat metabolism as well.
Mm-hmm. Now, we always hear of type 1 diabetes, type 2 diabetes, etc. What are the different types of diabetes? For example, type 1, 2, etc., etc.
Look, there's been a whole rethink on the classification, but to keep it simple for the more common types of diabetes, type 1 diabetes, as everyone is aware, is the type of diabetes that occurs in young individuals, and it is characterized by what we call an absolute insulin deficiency. And for that reason, as you know, if you're a type 1 diabetic, the only way to manage the diabetes would be with insulin therapy, because that is then the life-saving measure, without which, of course, there would be problems in terms of complications. The more common variety of diabetes that everyone sees is actually type 2 diabetes, which occurs in older individuals, which is characterized by insulin resistance, but also a certain degree of insulin deficiency. And that's the reason why we are able to control these individuals with medication in the form of oral medication initially, and some of them eventually need insulin. This is the variety, as they say, which is more common. Almost 90% of all the diabetes is due to type 2 diabetes, and often one has a family history of diabetes in these individuals. Mm-hmm. Then there are many other categories, but the ones just to remember is gestational diabetes, which is diabetes that occurs for the first time in pregnancy, as well as a few other conditions like latent autoimmune diabetes of adults. But I think for the listeners, food, to keep it simple, I think we should stick to this type 1 and type 2 diabetes, and because that constitutes the large majority of diabetics.
Just to remind our listeners, our topic for discussion is diabetes control. Our special guest is Dr. Hussein Randri, an endocrinologist and a diabetes specialist. And if you have any questions for Dr. Randri on diabetes, our WhatsApp number for your questions is 060 904 1056. I repeat, 060 904 1056. Now, Dr. Randri, what are the risk factors for developing diabetes? And what are some of the, I don't know if I can call it the causes of it?
Yeah, so no one exactly knows the cause of diabetes, but if we confine our discussion mainly to type 2 diabetes, which, as I told you, is the most common form, there are many sort of risk factors. For one, it is more common in certain ethnic populations. For example, the Asians, you see it in Hispanic populations, you see it in the Arabian population, etc. So there's the genetic factor which is related to race and ethnicity. Coupled with that is the fact that if you have a family history of diabetes, especially in a first degree relative, then of course you have a risk of developing diabetes. And as I pointed out earlier, the more common form of diabetes type 2 occurs in the older individual, usually above the age of 40. We're seeing more individuals at a younger age, but notwithstanding that, by and large, between 30 and 40 years is when individuals will develop type 2 diabetes. And then, very importantly, is against a genetic background, one of the most important environmental factors that leads to development of type 2 diabetes is, in fact, being overweight or obese. So that's a very important risk factor. And then, of course, together with that, if the individual is previously known to have a condition such as pre-diabetes, which is the stage between normal and diabetes, then there's a higher risk of that individual developing diabetes. If individuals are sedentary, do not exercise. Also, you often find diabetes clustering with other diseases. For example, individuals who have high blood pressure, those with cardiac disease, those with abnormal lipid profiles. I don't think that is necessarily a direct cause for diabetes, but there's often in these individuals a clustering of these metabolic and other diseases. And of course, there's one other condition which may be relevant, and that is individuals who have polycystic ovarian syndrome. This is a hormonal disorder that occurs in females, which definitely carries a higher risk of diabetes. So varied causes, but I would imagine that against a genetic background, to me, one of the biggest factors is being overweight and being sedentary and not exercising.
Doctor, questions come through. Is it correct that if you take medication for cholesterol, the statins, they can lead to diabetes?
Well, that's an important point, because there have been some studies, and there's a large epidemiological studies, and they looked at people who took statins and those who didn't take statins, and there was definitely a slightly higher rate of diabetes. But if you look at it in terms of risk-benefit ratio, I think that should not preclude the use of statins for their benefit, because their benefit outweighs the small sort of association that they've seen. I don't think we can call it causal, but there's they've seen a trend in statin uses.
Another question has come through. I would like to remain anonymous. I have a question for the doctor. What is insulin resistance, and what causes it, and why is the glucose insulin high?
Okay, so insulin resistance, put simply, is when the insulin in the body does not act as it's supposed to. In other words, it's a corollary to, say, sensitivity. So the body's tissues are not sensitive to insulin. So that's insulin resistance. Now, it's important to bear in mind that insulin resistance occurs at different tissue levels. And as a result of being insulin resistant, and one of the most important causes of being insulin resistant is overweight, obesity. So what the body does is, because of this insulin resistance, the body then tries to overcome that insulin resistance by producing more insulin in the body. So that is the body's coping mechanism to try and keep the blood glucose normal in the face of insulin resistance. That's why you'll find that the insulin levels will be higher in people with insulin resistance. And just to bear in mind that when you talk about type 2 diabetes, the first stages of type 2 diabetes, the background to type 2 is always insulin resistant in the large majority. And what happens is the body then initially starts to overcome that resistance by producing more insulin. There comes a time where that pancreas then is not able to cope with the production of insulin. So eventually you'll find the blood glucose slowly rising until eventually the insulin secretion becomes lower and lower until you develop overt diabetes. So I think the two are linked to one another.
Doctor, what are the common symptoms of diabetes?
So, many of patients are, the classic symptoms are excess thirst and passing a lot of urine and losing weight in spite of having a normal or increased appetite. But I must point out that, it's very easy in type 1 diabetes to detect it because they present in that way. They're ill, they're markedly symptomatic with these symptoms. But many of the type 2 diabetics that we see in the community actually have very little symptoms. And they often actually are diagnosed because they went to a doctor for a different reason. For example, they might have a non-healing ulcer, or they went to the ophthalmologist and found that there was a problem of bleeding in the eye, or they presented with a heart attack. What I'm saying is that very often we pick up type 2 diabetes quite insidiously, and to rely only on symptoms, you will miss a lot of the type 2 diabetics. There's a lot of patients in the community or subjects in the community who are diabetic who don't have classic symptoms. So you will always have a high index of suspicion for diabetes in the clinical context, meaning we spoke earlier about those risk factors. So you must be particularly aware of the possibility of type 2 diabetes in those with those risk factors.
Doctor, we often hear of pre-diabetic. What is the term pre-diabetic, and how does it work?
Yeah, so pre-diabetes, if you have to track how diabetes develops, you have normal glucose tolerance, and on the other extreme, you've got diabetes itself. So that phase between the two is called pre-diabetes, and we diagnose pre-diabetes. By the way, pre-diabetes is an asymptomatic phase. You don't get any symptoms during pre-diabetes, but it's you can diagnose it by a few laboratory parameters. One of them is to find that you have a fasting sugar that's in the pre-diabetic range, say between 6 to 6.9. The other way to diagnose is when you do a glucose tolerance test, and when you find the 2-hour level is between the normal and the diabetic range, between 7.8 and 11. So that's considered a pre-diabetic stage. And then one other way that you could indirectly assess it is if you don't want to subject yourself or the patient to a glucose tolerance test, you can do what is called the HbA1c. We often use that to assess the quality of control in our diabetics. And if that HbA1c is between 6 and 6.4, we consider those individuals to be pre-diabetic.
Thank you for that, Dr. Hussain Randri. We are discussing diabetes control on Medical Files, and our special guest is Dr. Hussain Ahmed Randri, an endocrinologist. And just to remind listeners that if you have any questions for Dr. Randri, you can forward them to us on WhatsApp on 060-904-1056. Just to remind you, the doctors and guests on Medical Files program will help you with any medical problems you pose by giving you advice on air. However, they do not have your full medical history and have not examined you. Please verify the advice given to you on air with your regular doctor who knows your medical history, your allergies, etc. Neither the doctors nor the relevant radio station nor the Islamic Medical Association of South Africa will take any responsibility for any adverse reaction caused by the advice given to you on Medical Files. Just to remind you again, if you have any questions for Dr. Hussain Randri on diabetes control, forward them to us via WhatsApp on 060-904-1056.
At Amina's Wonder Spice, we know that many of you already enjoy the pleasure of cooking with our 100% pure ginger and garlic. Our unique masala paste have created a new dimension and variety to your dishes. For all these reasons and more, we've called it a Wonder Spice. Amina's Wonder Spice, creating a unique taste in a paste. Available throughout South Africa, neighboring countries, and also in the UK. Contact us on 031 577 5023 or www.aminaspice.co.za.
Welcome to Simplex Radio. Visit our showroom for the full range of car audio. Our TV department carries top brands with quality LED panels, full HD to Ultra HD, and now the experience of Super Ultra HD. Visit our theater rooms and transform your home with brands like Onkyo, Integra, Denon, Boston Acoustics, Yamaha, and more for quality audio visual experience. Now available, full range of home appliances. A one-stop shopping experience. Call 031 306 4029 or Kenilworth Park, 202 Brickfield Road, Overport. Simplex Radio, the name you can trust.
Don't miss the celebration. Join us as we mark the first anniversary of Checkers Foods Kawi Park with a live broadcast from the store happening on Saturday, November 23rd from 10 a.m. to 2 p.m. Come hang with Zahir Basa, Salma Ghazi and Siraj Basa and enjoy a day packed with excitement, amazing giveaways and unbeatable in-store specials. Bring your family, friends and neighbors too. Everyone's invited. Save the date, Saturday, November 23rd at Checkers Foods Kawi Park. Checkers Foods Kawi Park is halal certified by NIHT across the butcher, bakery and deli. We can't wait to see you there. Checkers Foods Kawi Park.
Attention all plumbing and building contractors. Discover high quality plumbing supplies at unbeatable prices with Plumcore. From pipes to the latest tech, we have it all. Visit Plumcore today for expert advice, exceptional service and in-store discounts. Call 031 350 3737 or visit us at 16 Interside Avenue, Amgeni Business Park. Plumcore, your trusted partner in plumbing supplies.
You're listening to A View on Medical Files, brought to you by the Islamic Medical Association of South Africa, hosted by myself, Faisal MJ Suleiman. Our topic for discussion is diabetes control, and our special guest is Dr. Hussein Ahmed Ranri, an endocrinologist. Dr. Ranri, a question has come through. I am on metformin XR 1500 milligrams after dinner. My morning fasting blood glucose is 5.9 to 6.2. Before lunch around 1 p.m. and before dinner at 6 p.m., the glucose is around 5.7. However, when I do the GTT test, it is 17 at 2 hours. HbA1c is 6.0. Is the GTT of 17 worrying, and does anything need to be done in the light of the above other controlled results? I am 75.
Jazakallah for that question. I think we must clarify one point. Once an individual is diabetic, then it negates the need for doing a GTT, because the GTT is used to confirm diabetes and perhaps can be repeated at some stage later if you think that your diabetes is gone away or has gone into remission. So I would not use the 2-hour level during a glucose load. You normally take 75 grams of pure glucose as part of the GTT. So the 2-hour level and how high it goes is really not relevant. All it does, it confirms one is diabetic. Looking at this individual, I think that control is really for a 75-year-old excellent, because after all, you've got a very respectable fasting glucose. Even the daytime levels are good, and the overall 3-month average, which I alluded to, which is the HbA1c, is at, I think he said 6% or so. Mm-hmm. So I would think this individual is doing perfectly well. Ignore the levels on the GTT, because as I say, once you're diabetic, that GTT sort of recording or level is not relevant any longer.
Okay, I think brother goes on to say, salams, test HN1C, blood sugar test is 6.8. Do you recommend medication or controlling sugar using exercise, diet, etc.?
So I think what they're referring to is the HbA1c of 6.8. And I pointed out earlier, a level above 6.5 equals diabetes. Now, it's an interesting question, because in the previous years, before, at least when we first did diabetes many years ago, there was a feeling that initially one should start people on lifestyle measures alone, and that's diet and exercise and weight loss, etc. But the current treatment of diabetes is to say that in every individual, we couple that lifestyle change with medication. And of course, the first line of therapy is metformin. So in an individual who's got an HbA1c of 6.8, bear in mind that the recommendations throughout the world is to combine lifestyle with metformin therapy.
Okay, another question has come through. What is type 3 diabetes and does it have anything to do with Alzheimer's disease? Why is insulin not used for this?
So, as I pointed out earlier, there were different definitions of diabetes. Some would call it the individual that was initially on oral agents and now going on to insulin. It becomes an insulin requiring diabetic. So you can't call that individual necessarily a type 1 diabetic. It's a type 2 diabetic that has become insulin requiring. Now, as regards the association between diabetes, there's earlier question about statin and diabetes, there's definitely an association between diabetes and Alzheimer's. And the basis is probably the fact that when you're diabetic, you are prone to a lot of vascular damage. And as you know, that one of the causes of Alzheimer's is what we call multi-infarct dementia. And that is where you get small strokes in the brain. And of course, if you are diabetic and you're more prone to vascular occlusion, then definitely we find that Alzheimer's is, or multi-infarct dementia is definitely more common in diabetics as opposed to non-diabetics.
Salams, I have a question. I am 66 years old. I am pre-diabetic. My average glucose level is 6.9 over 3 months. That's a 3-month glucose average. What is your opinion regarding using medication or dietary requirements? Jazakallah. It then goes on to say test HN1C, blood sugar test 6.8. Do you recommend medication or controlling sugar using exercise? I think you answered that.
Yeah, I answered that question earlier, Ji. So again, the point is, I'm not clear as to whether the initial part refers to a blood sugar that the person has averaged out to 6.9, which is different from an HbA1c. If it is a HbA1c, then that individual would need to be on treatment.
I think she did clarify that it is HN1c. What is
no, HbA1c.
Okay, what HbA1c.
So in that individual requires treatment.
Okay. Jazakallah khair.
Sorry, just one point to make. Often we say that, our ideal blood glucose average should be under 7, but then the younger the individual, we sometimes aim for a level under 6.5. And in an older individual, we may relax the target. But remember that there's nothing to say that at a certain level that the risk of complications becomes completely non-existent. So in other words, what we're saying is there's a continuum of risk. So sometimes you feel your levels are not too high, but even at that level, you still carry some risk of complications. So therefore, I suggested that the recommendation is that patient be treated.
Dr. Andy, what are the goals of diabetes management?
So I think we can look at it overall. You really want to prevent the complications of diabetes. And we know there are a variety, and we can come to the types of complications. So the goal of therapy is to, on the one side, prevent complications, and we could add to that many ramifications with that. In other words, to have the patient become asymptomatic. In other words, the patient becomes now free of those symptoms. Also to enjoy a good quality of life. We mentioned prevention of complications, and of course to improve outcomes in terms of lifespan and reduce morbidity and mortality. So it's an all-encompassing objective in trying to control or manage diabetes, but in doing so, integral in that is the control of blood sugar.
And what are the different treatment options for diabetes?
So besides the lifestyle that we mentioned, weight loss, exercise, diet, etc., we have medications which are what we call oral medications, as well as injectable types of medications. Now, we alluded earlier to metformin, commonly prescribed as the first line treatment, and I think that still is the backbone of treatment for all diabetics, unless the patient can't tolerate the drug or has a reason for not being able to use it. Then there are certain categories of drugs that stimulate insulin production from the pancreas. Okay, we have the sulfonylureas. There's another category called the DPP4 inhibitors. And then there have been one or two other categories that have come and gone. But at the end of the day, in recent times, in the oral medication, perhaps more and more patients now on a new class of agents. We call them the SGLT2 inhibitors. And how these act is, when we have a normal individual, glucose gets filtered in the kidney and then it gets passed in the urine. These drugs prevent the reabsorption of glucose at the kidney level. So what happens is the glucose then goes down into the urine. It's a very important class of drugs, and we can come to their benefits over the other drugs. And the reason I'm emphasizing it is, while other drugs in diabetes that we had all these years, they used to benefit the individual by virtue of their glucose lowering effect. These drugs not only benefit you by glucose lowering, but they also have protective effects, particularly in two organ systems. One is the heart and two is the kidney. So I think that's, and in fact, one of the biggest advances in the treatment of diabetes, these new classes of agents have. Okay. Then in the injectable form, we know that insulin has always been around for a long time, but now, the big buzzword is the category of drugs we call the GLP-1 receptor agonist. And many people know because there's the drugs like Ozempic and Trulicity and Victoza. These are injectables, some of which are given once a day, others given once a week. And I think the attractive part about these drugs is that they have the benefit of having some degree of weight loss. They improve glucose levels, and in themselves, they don't cause the blood glucose to drop below normal. But over and above that, they also are a category that afford cardiac and renal protection. So it's interesting that we've now only in recent years got this array of drugs that will benefit the person in terms of serious complications.
Jazakallah khair. There's two questions which are related that come in. I'm going to combine them. Okay. The question says, can I reverse a diabetic state? And can diabetes be controlled only by diet? That's, well, this comes from one sister, the question. The second question comes from another sister, says, is type 2 diabetes reversible? What steps can be taken to reverse type 2? And what is the reversal success rate? I'm joining both these questions because they seem to be quite...
Yeah. So the second part of the first question already answered. Can I control? Yes, you can control anything with anything. But the recommendation is that if in this day and age, if you're type 2 diabetic, then you should control it with lifestyle coupled with metformin therapy at least, and some form of medication, and metformin being the first line of treatment. Okay. Mm-hmm. The second thing is a very pertinent question, and can diabetes be reversed? And what has happened is that the answer is yes. Individuals who, by whatever means, are able to experience a substantial degree of weight loss, sometimes up to 10-15% of weight loss. Mm-hmm. And in the past, we were able to achieve that. Some were able to achieve it with lifestyle, but many a times patients underwent what we call that bariatric surgery. And they found that those individuals that lost a significant amount of weight with bariatric surgery then had actually either gone from diabetes to pre-diabetes, and some had reversed their diabetes, so they became non-diabetic. And in that same vein, or in that same line of thinking, the drugs I mentioned earlier, those class of GLP-1 receptor agonists, the injectables once a week, in that family, there are now newer drugs that are likely to reach the market. In fact, one of them may reach our shores in early next year, where compared to what bariatric surgery used to achieve, these drugs are able to achieve a substantial degree of weight loss. And therefore, as we go into the years in follow up, with our management of diabetes, this concept of diabetes remission has now become a reality. In other words, it's possible to actually reverse diabetes. Remember that if you want to diagnose diabetes remission, you can't talk about remission whilst you're still on medical treatment of whatever sort. Okay. Being on treatment doesn't classify. You have to be off treatment for at least 3 years, and you have certain glucose criteria. For example, an HbA1c under 5.7%, which for at least 3 months of therapy, then you can, or you have a normal glucose tolerance, then only can you say that now my diabetes is gone into remission. So something which occurred uncommonly in the past is now becoming more and more a reality.
Okay, a question comes through. The sister says, please ask my question. I have type 2 diabetes and suffering a lot with peripheral neuropathy.
Ji.
I don't know if there's a question because the first two questions have been, they haven't come through. So it's waiting for this message.
Okay.
So I don't know if you can decipher what the sister is asking.
No, the one about peripheral neuropathy.
Yes.
No, very important question. So when we talk about diabetes complications, you get two types. One is called microvascular, which affects the small vessels. And there are three organ systems that get affected. One is the eye, two is the kidney, and three is the peripheral nerves. So that's what she refers to as peripheral neuropathy. And then, of course, you get what we call macrovascular disease, which involves the coronary arteries resulting in heart attacks, and the carotid and the brain vessels causing stroke, and the peripheral vessels causing gangrene in the leg. So she's referring to a microvascular complication called neuropathy. Now, this is one of the most troublesome and impactful complications of diabetes. It really affects the quality of life of individuals. They complain of burning, pins and needles, numbness, pain, and it's quite it's nerve-wracking. Although it's like a double-edged sword. So anyway, be that as it may, there are many medications for it. Probably the most important thing is to control the glucose properly, because often we find poor glucose control worsens neuropathy. But beyond that, one other thing to bear in mind is always check your vitamin B12 level if you've got neuropathic symptoms, because we know that low vitamin B12, which is common in the community, but also occurs with metformin therapy in some instances, can either be the primary cause or aggravate your neuropathy. And then there are a whole host of medications she may have tried. Some of them are analgesic, some are work on the neurological system. I'll give you some common names like Lyrica.
In fact, the first part 1 and part 2 of her questions were exactly. I'll just read because it didn't come through. It says, Salams, is there a cure for peripheral neuropathy or treatment to relieve peripheral neuropathy? Symptoms are burning, numbness, tingling pain, unbearable symptoms, although sugar is controlled. I'm taking Lyrica and Neurobion daily and don't want to live on meds.
Yeah.
So that was just
so unfortunately,
the same question.
Yeah, the same question. So look, Lyrica is one. It's called pregabalin. That's the generic name, and there are other drugs beyond that also work for peripheral neuropathy. So, the statement that my view is this: the sugar, if it's poorly controlled, it's a problem. You're going to tighten your glucose control. But if the sugar is normal, you may still suffer from neuropathic symptoms, and in which case, unfortunately, you can't say I would rather not live on, because if the medications are there to help you, then my suggestion is try and get to the lowest dose of the medication that keeps you symptom free.
Okay. Is metformin and glucophage the same? My husband is on glucophage and a lot of people had negative things to say, which is very scary.
This is probably one of the commonest myths that are around. And every day in the practice, someone is itching to ask the question or has been convinced that is the truth. There is really no truth to that. Let me just put it this way. Metformin and glucophage is the same thing. There are many preparations. Glucophage is just a trade name. Metformin is. So metformin and other varieties of metformin, including glucophage, are the same. Now, there is no truth in the fact that metformin is harmful. Many people misunderstand when they talk about damage to the kidney. Metformin itself does not damage the kidney. The only caveat is that if your kidney function deteriorates to a certain level, then one may need to reduce the dose of metformin or stop it completely at a certain level. That's different from it causing the damage. So too may you need to stop many other drugs or reduce the dosages of many drugs when you get kidney disease. So let me dispel this myth that lies around in the community that metformin is harmful. In fact, if I had to put it in, if you look at the number of diabetics throughout the world, say assuming now we got say 560, 70 million diabetics worldwide, with few exceptions, the majority of people who have diabetes any part of the world are started off on metformin. So if there was truth in that, what do you think the
Exactly.
state of the world will
Of
be
course,
at this stage?
absolutely.
Huh?
Anyway, doctor, it's time for us to take an ad break. But after the ad break, the questions come through is there any relationship between having COVID-19, then suddenly followed by pre-diabetes? But after that break.
The chaos and destruction in the Gaza Strip is beyond comprehension. Virtually everyone is displaced, hungry, and in urgent need of life-saving humanitarian support. The Al-Imdad Foundation has been working tirelessly to address the health, nutrition, and water needs of the population. Our hospital, water deliveries, and hot meal programs are made possible with your support. Your donation, big or small, is a lifeline for those in dire need. Help Gaza survive. Donate online at alimdad.com or call 0861 786 243 for more information.
Come get our butcher's best for less at Checkers Foods Kawi Park. Enjoy certified halal butchery products like Championship Boerewors thin, just $98.99 per kg. All beef roast, just $99.99 per kilo. And tenderized beef steak, just $89.99 per kg. Deals valid until Tuesday, November 19th. Only at Checkers Foods Kawi Park. Now certified by the NIHT, the National Independent Halal Trust, across our butchery, bakery and deli.
This segment is brought to you by Kenfield Auto, your RMI approved service and repair specialist. 236 Brickfield Road, Overport. Kenfield Auto.
بسم الله الرحمن الرحيم ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا
Car won't start?
Kenfield Auto.
Noisy brakes?
Kenfield Auto.
Due for a service?
Kenfield Auto. Kenfield Auto, the answer to all your car problems. Your service and repair specialist for your VW, Audi, Suzuki, Toyota, or just about any vehicle. Kenfield Auto, your RMI and insurance approved workshop to handle them all. 236 Brickfield Road, Overport. Call us on 031 207 2399. Kenfield Auto.
You're listening to Medical Files, brought to you by the Islamic Medical Association of South Africa, presented by myself, Faisal MJ Suleiman. Our topic for discussion is diabetes control, and our special guest is Dr. Hussein Ahmed Randri, an endocrinologist. Any questions on diabetes control, please forward them to us via WhatsApp on 060-904-1056. Now, Dr. Randri, just prior to the ad break, I had posed a question. Is there any relationship between having COVID-19, then suddenly followed by pre-diabetes?
And that's a very nice question, because certainly some observation that we had made during the COVID pandemic, and of course also reported in the literature. And there's no doubt that there were patients that when they developed the COVID-19 infection, subsequently developed diabetes. Now, there are certain theories, one of which is that maybe the COVID virus did directly attack the pancreas, and in so doing caused the diabetes. There are other theories where perhaps individuals were anyway genetically predisposed, and this trigger of the virus just brought on the diabetes. Also, some of the patients who had COVID, and especially the severe COVID, were given steroids, for example. And we know that steroids does bring the blood sugar. But there is no doubt that there was a definite association with COVID-19 and the subsequent development of diabetes, or whether it's diabetes or pre-diabetes, but both really were more common after COVID.
Salams, are high blood sugar levels linked to the onset of cataract?
Yes, absolutely. If you look at the sort of eye complications of diabetes, we spoke about it earlier, that we often speak to the condition called retinopathy. But cataracts definitely are more common in diabetics compared to non-diabetics. They, of course, occur as people grow older anyway. But yes, diabetes is one of the causes of sometimes premature cataract appearing.
Dr. Randri, what are the potential complications of uncontrolled diabetes? And what is your advice for screening for these conditions?
So we spoke earlier about those micro and macrovascular complications, the eye, the kidney, and the nerve, as well as the large vessels. And the important thing is, and I think that this is a very important lesson to everyone who has diabetes, sometimes it requires their prompting to get themselves sorted out because it's overlooked. For example, if you're thinking of eye disease, it is recommended that at least once a year the diabetic patient visits an ophthalmologist who is able to dilate the fundi or the eye and screen for a diabetic damage in the back of the eye. We call that retinopathy. Okay, and it's very important. And many times individuals say, but there's nothing wrong with my eyes, I can see correctly. That's not the issue. There's a difference between seeing the optometrist for your visual acuity as opposed to looking for bleeding in the back of the eye. Sometimes an optometrist is able to, or has the equipment to be able to take a photograph and screen for retinopathy. It doesn't matter who does it, but it has to be done. The second part is that of the kidney. We call that nephropathy. And for that, we normally screen by doing a blood test where we measure the creatinine level. But one of the earlier signs of diabetic kidney damage is the presence of protein in the urine. And that protein is not detected by what we call a dipstick. That requires a certain level of protein to be above a certain threshold to be detected. But there is what we call the detection of a low or to detect an albumin creatinine ratio, they call it, in a urine sample. So remember, don't be fooled by just having a normal, say, ultrasound of the kidney or what. To detect it, you got to do a blood test and or a urine test to look for that protein. I spoke about the eyes. As far as the nerves are concerned, again, the symptoms we spoke about earlier for the neuropathy, and a doctor will test for neuropathy by using perhaps a monofilament, where you ask the individuals if they can feel the sensation of the monofilament, or they use a tuning fork to detect vibration sensing, which gets lost when you get neuropathy. So all of these things are things that you regularly need to check in the individual with diabetes. For the big vessels, of course, the doctor will often feel your pulses in your leg to see if they are diminished or absent, to suggest that you've got blockage of your peripheral vessels. They may check your carotid vessels to see whether there is any blockage for the blood vessels that's going up to the brain. And of course, individuals where there's a suspicion of cardiac disease, especially the symptomatic patient, they may undertake an exercise stress test to try and determine whether there is any evidence of coronary artery disease. So all of these things, the screening of this is imperative. Many an individual is diabetic for many years, but has not had these measures taken. And sometimes we see the downstream catastrophic event taking place. For example, suddenly the guy or he or she gets a bleed in the back of the eye, when in fact you could have become proactive and prevented the complication.
Assalamu alaikum. Will Ayurvedic medicine help type 2 diabetics?
I don't know much about Ayurvedic medicine because I'm not an Ayurvedic doctor. But just while we're on that subject, there are some isolated care sort of studies that have shown the benefit of certain compounds. Okay, for example, cinnamon has been quoted. So I must say that the effect on blood glucose levels of these medications, and I'm not speaking about Ayurvedic medicine, we're talking about the other natural, is very marginal. And invariably, I always tell individuals, don't make that the sole form of treatment you're using. If you find you're on medication and you found that you added this or that and it made a difference and brought your glucose, by all means, there's no problem with that. But don't default on conventional medication, because that's what's evidence-based, there's science behind it, and there's proven benefit.
Salams, we noticed my grandson's neck was very much darker than the rest of his body. He's since been diagnosed with insulin resistance. Some guidelines will be greatly appreciated. My grandson is 10 years old.
Okay, so we spoke earlier about insulin resistance, and often, as I say, in the younger individual who is overweight, you get the chubby child, for example, they have insulin resistance. What is being described is a condition called, or a physical finding called, acanthosis nigricans. This is a brown, black type of velvety pigmentation that occurs in the nape of the neck. You may find it in other areas, including the axilla and the groin, etc. So this is called, and this is what we call a cutaneous marker of insulin resistance, right? Remember that this is a indication that the individual must now embark on a lifestyle program to try and keep the weight down, to exercise, to eat healthy, because no doubt we know that insulin resistance carries a future risk of diabetes. So this patient, as long as the blood glucose, etc., is normal now, just precautionary measures so that the person, you mitigate that future likelihood of diabetes.
Doctor, it's almost time for us to round up. We've got like about 4 minutes left for the program. But the question we pose to you is, what one change can listeners make today to reduce the risk of developing diabetes?
I think if one just takes a simple, non-expensive approach, we're not talking about medication, just make sure that you don't become overweight or obese, that you eat healthy, and that you exercise regularly. I think those are probably the most cost-effective and most impactful ways of preventing yourself from becoming diabetic.
And what are some promising areas or advances in diabetes treatments?
So earlier we spoke about the newer agents, and I talked to you about a new drug that might come out in the new year in that family of what we call incretin compounds. Also, it's interesting that throughout the world they've been looking at ultra fast acting insulins. There is a lot of hype now about once a week insulins that haven't reached our shores yet. So there's a lot of advances in different areas. So designer insulins, ultra fast acting insulins, ultra long acting insulins. In that family of drugs that I spoke about, which cause the weight loss, there are a whole host of combinations of therapy that promise, a much better weight loss and much better control of diabetes, and some, of course, afford you the cardiac and renal protection. So I think there's a lot that's in the horizon, and I'm sure that patients will benefit from these in the years to come.
I'm going to take one more question, doctor. How does diabetes affect other health conditions?
So we spoke about the complications, right, about diabetes, but I mean, when you say other health conditions, we've spoken a little bit about dementia. We speak about what you call depression, very important. There's no doubt that in general, especially the overweight diabetic, they more often have depression compared to others. We've spoken about the association with blood pressure and cholesterol and other cardiac complications. So if I can summarize it in one word, I find very few organ systems that are not affected by diabetes, and the association of diabetes is so vast with so many conditions that I think if we can reduce the burden of diabetes by preventing it, we will make a huge impact on many aspects of living.
Dr. Hussein Randri, Jazakallah khair for joining me on the program this evening and for having shared that information with us. I'm sure our listeners have benefited, and may Allah SWT reward you for your sacrifice and all that you do for the profession.
I mean, Jazakallah
and
khair.
I say Jazakallah khair for joining me. It's time for us to round up, and I want to thank all the engineers in the various radio stations for having engineered this evening on Medical Files, and I want to thank you for the sterling piece of work done. Enjoy the rest of the evening, and for myself, Islam J. Sulaiman, until we meet again, it's Assalamu alaikum wa rahmatullahi wa barakatuh.
The Al Ansar Foundation, Da'wah, Tarbiyah and Education, establishing the foundation